Hey everybody, Dr. Sajewicz here, and today I want to give you a cool example of what we can do with oral contrast. Okay, so let me set you up with some clinical history here. This patient went for an endoscopy. They were dilating a narrowing in the esophagus, and the patient was having some chest pain afterwards. So the GI doc ordered a CT scan, and they wanted to look for an esophageal leak. Okay, great. And now you could do traditional, barium type study. You'd probably want to use water-soluble contrast first, but I tend to like CT for a lot of these types of exams, right? Rule out esophageal leak, rule out like an anastomotic leak, because on a traditional, barium type study, or a fluoro study, you can't really see behind structures that well. You actually literally have to turn the patient to see behind the esophagus, right? So if you're looking AP on a fluoro study and the leak is backwards or forwards, well, then you can't really see that. You have to turn the patient sideways. However, on a CT scan, you can see everything, okay? And now you can't use the same strength contrast that you're going to use on a fluoro study that you're going to use with CT. It would be just like way too bright. It would be like 100 times brighter than bone. Okay, so here's bone over here, and it would just cause so much artifact you wouldn't be able to see anything. Well, on CT, we just take the gastrographin that we use in our institution and we dilute it. And well, how much do you dilute it? Well, we use a 3% solution for most cases. So, well, what does that mean? Well, we put 30 cc's of gastrographin in 1,000 cc's of water. Okay, so that's how we get our 3% solution. And then we have the patient drink probably about 100 cc's for the study. And that's typical for an esophagram type exam on CT. And maybe if you want to look at the upper stomach, or if we want to look at some sort of bariatric surgery case, you could have the patient drink more contrast if you need to see a little bit lower down in the stomach, or maybe the duodenum or upper jejunum. But then you just have to wait a little longer. So for this type of study, patient's drinking the contrast, and we're imaging like as soon as the tech is done doing the scout images. So let me show you this case. All right. As you can see, there's air everywhere in the soft tissues. Okay, this is a very thin patient. It has no fat whatsoever. Okay, so normally you see a lot of fat in the chest wall, and here this patient just so cachectic, there's no fat whatsoever. And there's air, and let me just play with the windows a little bit. There's air throughout the mediastinum. This patient has pneumomediastinum. There's no pneumothorax, but so you have air here surrounding the heart. That's all compatible with pneumomediastinum. It's surrounding all the mediastinal structures. And then once air gets into the mediastinum, then it typically goes up into the neck and into the chest wall, and that's what we can see here. Okay, so if we make the windows a little bit darker, now we can see the contrast that the patient drank. Okay, so right in the middle, this is the esophagus. So you go from top to bottom, and so far here's some contrast, more contrast, and no contrast is seen leaking out of the esophagus. So we can safely say, in this case, this patient does not have an esophageal leak. They had at least some sort of hole created at one time, and a lot of air got out, but there's no leakage of contrast at the moment. So they'll probably watch the patient for a couple of days before they try to start like a clear fluid diet, and they'll manage the patient conservatively. Now, let's talk about this contrast dilution. See, it's very bright here in the esophagus, but it's not overwhelming. It's not causing a lot of artifact. In big patients, so like really obese patients, we have a special bariatric protocol for those. Or maybe it's a rule out esophageal leak just on a large patient. Well, the larger you are, the more, let's say, photons your body is going to be eating up, right? Before the X-ray photons can get to the detectors, and you're going to get a lot of, what we would call quantum model type artifact, right? It's just going to look very pixely. It's not going to be very good images. Well, in those patients, we go up to sometimes a 10% dilution, okay? So 3% for thin patients. This is obviously a very thin patient. And then you can go up to a 10% mixture on those large patients. So, yeah, I just wanted to show you that case. I also wanted to announce something that I'm working on for you guys. I'm working on a contrast course. Okay, so this is going to be everything to do with contrast with regards to CT. And not only going to talk about IV contrast, we're also going to talk about GI contrast. So at the beginning of the course, we'll have preparation and prevention. We'll talk about how to prevent contrast-induced nephropathy. We'll talk about allergic reactions and how to prevent those. And then we'll get into the injection part on doing IVs and what do you do with all those power lines, power picks, and central venous catheters. Then we'll talk about extravasation and what to look for and how to prevent that. And we'll get into how to recognize a contrast reaction, because that's really important for you to be able to do. And then what do you do when a contrast reaction occurs? And then we'll go over some special conditions, like do you do anything differently when you're giving contrast to children or pregnant women or women who are breastfeeding? Of course, we'll talk about GI and GU contrast, and we'll throw in dialysis as well. Like what do you do with those dialysis patients? So that's all I wanted to share with you guys today. I'm working on that. If you haven't gone over and downloaded my free imaging prep guide, please do so. It's always going to help you out. You can print it out and read it in about a half hour. Of course, it costs nothing. Okay, that's at www.imagingprepguide.com. Okay, just all one word, no hyphens or anything like that. And I'll see you next time.